choosing the topics for this important event. And I would like to thank Dr. Ashraf Badawi, the head of IRIS company, for the great organization of this meeting. Actually, this event is discussing a hot topics in both coronary and structural heart disease. This is one of the coronary complex intervention, a PCI in complex anatomy, actually a case with triple bifurcation and osteal right coronary stenosis. I call this case a case when you can't stop, and I will tell you why. This is a 56-year-old gentleman. He's diabetic, dyslipidemic, presented with typical exertional chest pain, Canadian class 2 to 3, with true syncope 2 weeks before the diagnostic coronary angiography. And coronary angiography, actually, this was not done by other operator, was done in April 2021. And this was a coronary angiography of this gentleman. As we see here, that left main looks to be diseased, atherosclerotic. The LAG also is a diseased artery and give a big long diagonal branch that shows osteal significant lesion. The circumflex also shows a significant lesion. And the first obtuse marginal branch is subtotally occluded. And as we see here that the LAD in the mid segment has a significant lesion. The diagonal branch is a big long artery with also a long plaque starting from the ostium extending very long in this diagonal branch. It is a bifurcation. Also the circumflex obtuse margin is another bifurcation lesion. And this is his right coronary artery. Actually, there was a significant stenosis. In the mid segment of the right coronary artery, that is was tortuous and dominant artery. Also, there was a plaque at the ostium and the proximal part of the right coronary artery, and the decision at that time to refer this gentleman for surgery. The patient refused completely to go for surgery. That's why he asked for another opinion. I decided to do an FFR guided intervention for this gentleman because in the previous angiography, they mentioned that there was significant stenosis in the distal left main, as well as in the osteal LAD and osteal circumflex. So I decided to go with an FFR guided intervention. This is a transphalangeal approach, an XB guiding caster. And I did the FFR. Actually, the obtuse marginal and the diagonal branch, they didn't require an FR because this subtotal occlusion, and the diagonal actually is a significant lesion. I did the FFR for the proximal LAD and the proximal circumflex. And this is the FFR. The LAD mid segment was significant, and the osteal and proximal lesion was not significant. The LCX osteal lesion was not significant as well. So my decision to go for intervention of the LCX obtuse marginal bifurcation, then for the LAD diagonal bifurcation, and see what the results of this decision. Actually wired both the obtuse marginal circumflex, lesion preparation with balloon, stent deployment. This is a provisional stent technique from the circumflex to the obtuse marginal. And after that, we used a non-compliant balloon to properly deploy the stent. We like to use the stent boost or clear stent just to show that the stent is well deployed. I will show the results. This is the result after stenting of circumflex obtuse marginal, and look at the proximal part of circumflex. Actually, the IFR was not significant, but you feel that this proximal lesion could not be left like this. So I left a wire in circumflex and I went for the LAD diagonal bifurcation. I did a DK crush, starting with the diagonal because it was a long artery with a long stenosis. Lesion preparation in this case is very important, to dilate first and then to put a stent in the diagonal, protruding a little 1 to 2 millimeter in the LAD and having a balloon in the LAD. Start stent deployment, and then we crushed the stent with the balloon in the LAD. Taking off the wire or leaving the wire in the diagonal is an optional. You can either remove the wire from the diagonal before crush, or you can do the crush with the balloon while the wire is still there. And this is after stent deployment, and we crushed the stent with the balloon. And then we recross again to the diagonal for the first case. And for dicky crush, it's preferred to cross in the mid or the distal part of the stent. And this is crossing through 2 layers of metal to the diagonal branch. Preparing for the first case. And this was the first case. And after that, we have, in this condition, we have to remove both the wire and the balloon from the diagonal. Then we stented the LAD to complete crush the diagonal stent. And this is the LAD stent. It was a long stent because also it was a long lesion. And after stenting of this LAD, crushing the diagonal stent, we have to cross again to the diagonal artery. And this is after stenting of the LAD, we recrossed again, and this recross is through 3 layers of metal, the 2 layers of the crushed stent and the layer of the LAD stent. Then we crossed, and we did the second case. But I would like to look at the proximal part of the LAD. Also, I'm leaving a wire in circumflex in case, and we have to look at the proximal part of the LAD. Actually, the IFR told us that this was not significant for both the LAD and circumflex, but look at this proximal part of the LAD and this proximal part of circumflex. That's why I call this case a case when you can't stop. I couldn't leave this patient with this bad proximal part of the LAD and proximal part of circumflex. Look, and even there was some proximal edge dissection of stent in the LAD. Anyone can leave this anatomy like this. That's why a decision was made to do a left main intervention, another DK crush for this left main intervention, and already I have a wire in the LAD, I have a wire in the circumflex, and starting again a lesion preparation, dilatation of circumflex and the LAD, stenting the circumflex, again with 1 to 2 millimeter protrusion of stent in the left main, having a balloon in the left main LAD, then deploying of stent in the circumflex with this protrusion, overlapping with the previous one in the circumflex OM. And after that, we crushed the stent with the balloon in the left main LAD. Then again, we recrossed again for the first case. And after that, we removed the wire from the circumflex and stented the left main LAD. Actually, the stent extends to the ostium of the left main because it looks to be diffusely diseased. This is not the actual size of the LAD. Maybe IVOS here could be a good option. So stented the left main LAD, extension of stent to the proximal part to the ostial of left main, and definitely the stent size chosen based on the LAD diameter. we deployed the stent. The best view for the ostial left main is the LAO cranial view, and then we deployed the stent in this view, overlapping with the previous stent in the LAD. And after that, again, we have to recross again. I did both first. This boat was a 5 millimeter non-compliant balloon, and after both, I recrossed to the circumflex for the second kiss. This is after both, and this is again recrossing to the circumflex for the second kiss, and this is the second kiss. And in left main intervention, you have to end up by approximate optimization. Final kissing inflation should be followed by approximate optimization. That's why I did the final pot for the left main with these final results as regard the LAD diagonal bifurcation, the left main LCX bifurcation, and a provisional stenting for the circumflex obtuse marginal bifurcation. The patient was stable, tolerating the procedure, and everything went very smooth. That's why I decided to go for intervention of the right coronary artery, the mid segment of the right coronary artery, as well as the ostial right coronary artery. These are the final results, nice results as regard LAD diagonal, left main circumflex, and circumflex OM PCI. I went for intervention, and it was an easy one. In spite of tortuosity of this right coronary artery, the wire passed smoothly, like this. Then I did a direct stent to the mid segment of the right coronary artery, and as we see here, the proximal part and ostium of the right coronary artery was significantly involved. After stenting of the right coronary artery, I went for a stent of the ostium and proximal part with short stent. It's very important here to have the guiding caster outside with a very minimal protrusion of stent. Once you are sure that you are covering the ostium and proximal part, I deployed the stent. And this flaring of stent at the ostium, and this was the final result. Actually, with the 7 stents, one is circumflex, 2 in the LAD diagonal, 2 in the left main circumflex bifurcation, and 2 in the right coronary artery. Actually, all of this was in one session, and all the procedure was done through the transradial approach. That's why we can use a transradial approach for complex intervention. Even we can use it for bilateral radial for patients with chronic total occlusion. And this is the final results. And again, it's very important if we have this option in the cath lab, a stent push or clear stent, we can use it to be sure that the stent is well deployed, and also the stent is crushed well in the, when we use a decay crush. Why I prefer a decay crush in bifurcation lesion when we decide to go for 2-stent technique? Because we have actually a randomized clinical trials showing that this technique is even superior over the provisional stenting. The decay crush technique, we have an old study. This study showed, comparing the decay crush with provisional stenting, showing a trend towards lower target lesion revascularization and target vessel revascularization. Also, we have a new one, a new study published in the American College of Cardiology in 2019, showing that the restenosis rate in the first, second, and third year is significantly less with decay crush as compared with the provisional stenting. Thank you for your attention.
Thank you, Nabil, for these marvelous results, which give us a very important lesson that even if the investigations before the procedure is telling us something, that we can change our decision during doing the case. Uh, uh, there is a minute for discussion, or we should cut? Okay, okay.
Dr. Caesar? Dr. Caesar,
Hello?
this is Nabil Farag.
Yeah.
How are you?
Fine, thank you. Good morning.
Good morning.
You?
I would like to thank you very much for your continuous support. And every year you are with us, and we are happy to have you with us in this meeting, the cardiology department at Shams University, with your great department, and you are actually a great professor, Dr. Caesar.
Now the pleasure is for us, and we are very, very proud to accept your invitation. We have been working together for, well, yeah, a long time.
Very
10
long time,
years.
yes.
And it's a very good experience for us, for me, and for our group. So again, thank you very much for invitation to invite us this year. You know that every time you meet us, we will be here to support any idea that you can have in the future. Thank you very much.
And hope next year to have you with us physically in Egypt, inshallah.
That will be fantastic to see you in person. And please say hello to our friends and all the doctors that have been with us training in the CAD lab. Thank you, Nabil. And
Thank you.
Best wishes.
Thank you. I have two questions, Dr.
Yes,
Nabil.
Ahmed.
Firstly, thank you for this excellent presentation about complex anatomy, two levels of bifurcation and three vessel disease. My question is preferable to do the right coronary to support the left circulation first, or to do the left circulation and leave the right coronary to the end of the procedure? Second one, the role of IOS to detect the size and proper deployment of the stent in the DK, after DK crush technique in the left main. What is your opinion about that?
Thank you, Ahmed, for these two important questions. First, if my decision from the start to do a left main intervention, definitely I will go for the right coronary first, then I will do the left main intervention followed by the right coronary. But my decision was based on the FFR, that I can go for the circumflex fused marginal, then the LED diagonal, and there was no plan to do left main intervention. That's why I started with this first. But the procedure put me in that way after doing the obtuse marginal and the LED diagonal to stand the left main. That's why I continued the procedure to do the left main followed by the right coronary. But you are true that in case of left main intervention, it's preferred to do the right coronary. If we have a significant lesion, you do it first. And if we have a total occlusion of the right coronary artery, you do the right coronary first. And if this takes a long time, you can postpone the left main 2 to 4 weeks after and do the left main. But the right coronary is very important to support you during left main intervention.
This raises two issues. First, you can change your mind during your procedure to upgrade, optimize the results. And second one, to what extent we depend on the IFR to assess the lesions? Yes, and geographically it's very significant ostial circumflex and maybe borderline LED lesions. This is angiographically. Depending on IFR, which is a physiological assessment of the lesion, what is its value? Depending on, angiographically, I will do it for the proximal circumference without going to the IFR. IFR results is 0.94 for this site of lesion. It's very insignificant hemodynamically percent. The role of IFR actually, depending on for how the extent of its value.
Yeah, based on the randomized control trials, FFR or IFR is recommended in lesions up to 80% stenosis. And they found that some of these lesions are physiologically insignificant, and you can leave these lesions safely, and the prognosis and outcome to leave this lesion based on the IFR or FFR is great, is excellent, actually. That's why you can depend on this physiologic assessment, actually. And
in
sometimes,
this case particularly, you can leave the ostial circumflex like that, depending on the IFR, and start waiting for the complaint of the patient, or to do it in spite of IFR is not significant.
actually, what happened in this case, that after doing intervention of the obtuse, that's why from the start, I left the wire in circumflex, because I felt that the proximal part of circumflex is not healthy, and I had the feeling that it's risky to leave this circumflex like this. Also the LED, that's why I proceeded. I omit the IFR side, and I did intervention based on this angiography. IVUS could be a very helpful tool in this condition, but unfortunately,
Multiple imaging and multiple ways of assessment of the lesion is important in this situation, I think. The IVUS plus the
Yes.
IFR is very significant. I appreciate what you did. It's excellent results and excellent demonstration for the crush, which is a very important way to do bifurcation lesion, especially in the left main, and demonstrated by the result of the studies is lower target vessel revascularization, especially in the ostium of the circumflex. Many thanks, Dr. Nabil.
Last question rapidly. Why, Nabil, you don't choose to use the IVUS from the start? There is some information before that the lesion in the left main LED is significant, and you decide to depend only on the physiological. Why you do not use the IVUS from the start to give you better choice of the decision of making this case?
Thank you, Dr. for these important questions. Why I choose a FFR and not the IVUS? If I have a left main lesion, that's a borderline lesion, in this case, IVUS will be superior to FFR. But if I have a proximal LED or proximal circumflex borderline lesion, in this condition, physiologic assessment will be superior to imaging. Angiography, the left main looks okay for this patient, but the proximal LED and proximal circumflex was having a long plaque. That's why I decided to do FFR guided intervention in this.
But usually from the experience that when we have a very proximal lesion in the LED, usually it is extending to the left main.
Yes.
And in this condition, one wants to know exactly what is the situation. Maybe if you decide from the start to combine the physiological with the anatomical, this would be
This is a great idea. Both FFR and IVUS would be very helpful in this particular case.
Thank you. I think we have to shift
Dr.
now.
Walid,
Thanks, Dr. Nabil, for your excellent challenging case. But if you are applying the IFR in this case, according to the RIPCORD trial, which released recently in the ESCC 2021, which approved that no need for routine FR, no increase in the cost, no increase in the cardiac events. It has no value in cases of multiple stenting. How can we apply this trial in this case?
actually, one of the views I showed that there was a proximal edge dissection after stent deployment in the LED. And this edge dissection compromised the proximal part of the LED. That's why I omitted the FFR. And if it's an ostial LED, so a decision to go for left main intervention. And left main intervention, why not to do circumflex as well? This is
Yes.
actually, you know, it drive me. I was not the driver. The procedure was driving me for this way of management, actually.
Thank you.
We have to go to the next speaker. It's a live inbox retrograde CTO presentation by Professor Isaac Ovindo Video, Spain. Dr. Isaac, start, please.
Please, can you hear me?
Professor
Can you
Isaac
hear me
is a
now?
professor of cardiology,
Can you know me?
consultant in interventional cardiology at the University Hospital of Australia, Video University, Spain. Dr. Video,
Okay,
اتفضل.
thank you very much for attending. It's my pleasure to be here today virtually for this excellent meeting. I would like to thank the organization for the invitation, and it's a pleasure for me to share this complex PCI case with you. The main objective of this case is to summarize the step-by-step approach of a complex CTO case, and we are going to cover this with a life in a box case. The clinical presentation is a 70-year-old man with hypertension, obesity, and tobacco intake, with angina pectoris CCS3 class, despite optimal medical treatment, and with a stretch echo that showed inferior wall ischemia, with moderate depression in the left ventricular function. So here you can see the left angiogram. You can see moderate but not severe stenosis in the LAD, the medium LAD. And now you can see several collateral branches going to the right coronary artery territory. Now a new projection. Here you can see the left coronary angiogram with a huge collateral branch coming from the distal left circumflex to the right distal, to the crus corbis, and we can see posterolateral and posterior descending arteries with this retrograde funding. And in the right coronary artery, you can see severe stenosis in the proximal segment, and also the issue of the day, complete total occlusion in the mid segment. Complex, anatomically complex, because of the high score in the JCTO score, because of the blunt stop, the lateral branch, the length superior of 20 millimeters, and the presence of calcification. But moreover, you can see coming from the left two other characteristics that give the lesson more complexity. The ambiguous distal cap and the presence of distal bifurcation in the distal cap. So examining the collateral circulation, you can see poor branches, poor septal branches coming from the LAD, and the main for sure branch is the epicardial one that is coming from the circumflex. So planning the CTO approach, we always use the hybrid modified algorithm, and we many times start with a primary antegrade approach. So in order to do this, we use this material, two vascular axes, right femoral 7 French and right radial 6 French, and the guiding catheters that you can see in the slide. It's Travacat for the left and Atlas right for the right. First of all, we start with regular PCI for the severe stenosis of the proximal segment in order to allow us to go with deep intubation in order to plan more aggressive maneuvers. So we implant a driver to stent, regular one, an erroneous stent, and it works. So we go with the first step, the antegrade attempt for our lesion. So we start with a Caravelle microcatheter from Asahi with a Sion, regular Sion, in order to start with the navigation into the proximal cap. And then we proceed with a wire escalation, and we use a guide Sila extension catheter in order to give us more support. We progress with the navigation with an ultimate 8-gauge Asahi wire. But at this time, we decide to change for a Gaia first in order to progress with the navigation in the body of the occlusion with good feelings, but not absolutely sure of being in the true lumen or subintimal. So we check it properly, and we think that we were going subintimal. At this point, we proceed with several different projections, and at this point you can see that we are absolutely out of the lumen, we were subintimal, and then in this point we remove the wire, come with ultimated gain, and then at this point we decide after 25 minutes of procedure following the algorithm, we decide to go for a retrograde approach. At this point, we start with the double catheters that we mentioned, and we go with a microcatheter anterograde with the left main. We cross the microcatheter with the CM wire crossing the epicardial branch, and we start going retrograde with this. And in the antegrade approach, we maintain the sire wire in the lumen that we have reached in order to guide the progression of the new wire. We exchange the wire, we introduce a new wire, stiffer wire, in order to navigate, in order to negotiate with the distal cap. This is still the CM wire, and then we progress with ultimated loss. Again, but we can't enter into the true lumen. We can't progress in the proximal cap, because at this point we always go subintimal. So we decide to perform a reverse regular cut. You can see here the inflation of the 220 balloon in order to expand the lumen, the antegrade, the connection between the antegrade with the retrograde lumens at this point. But in this point we can't achieve the good lumen, so we decide to proceed with a new and not well-established maneuver, but I think a maneuver that was really useful for us. Here you can see the difficulties that we have progressing in the lumen. So we decide to advance an extension catheter, a boosting catheter from Asahi. We decide to inflate the balloon here, and then to progress the extension catheter into the connection lumen in order to avoid the collapse of the connection lumen that was happening in between the true lumen antegrade and the retrograde false lumen. So we decide to, after several inflations, to anchor and to advance, as you can see here, the boosting catheter, and to impact it in the connection lumen in order to facilitate the navigation with the retrograde wire that was a Gallia third with caravel microcatheter support. So in the next slide, you can see that we were trying to enter into the lumen of the boosting, and now here it is. Now we are progressing, and now we have reconnected into the right coronary guiding catheter. So now we have the connection. At this point, we decide to progress with the microcatheter, as you can see here. We introduce it across the guiding right, and then we connect with RG3 from Asahi, the externalization wire, in order to complete the loop. At this point, you can see the loop connection in between the two accesses. Now we proceed with the antegrade procedure. We go antegrade with microcatheter caravel, and then we place it in the distal part of the vessel, and then we exchange the RG wire sterilization with a high support wire. We predilate hardly on the body of the artery, and we proceed with three new stents, three drug-eluting stents covering on the artery, And here you can see the result after the implantation of the 3 new stents overlapping with the previous that we have implanted in the right coronary artery proximal. And this is the final result with a very good expansion of all the stents and a very good flow in the distal branches. And here you can see the connection in between the right and the left circumflex with flow competition at this point. So this is our final result. And please let me just a few seconds to share with you our take-home messages. First of all, complex CPOs should be attempted following a pre-planning algorithm, a pre-planning strategy. I think this is the most important during these procedures. Reverse card technique is an effective solution for re-entry into the proximal cap when we are going retrograde, but the use of some abilities, some tricks like the extension of guide catheters like boosting catheter may help us in this scenario. Thank you very much for your attention and for this kind of invitation.
Thank you, Dr. Isaac, for this nice presentation of your case. I have 2 rapid questions. Question number 1, if you have a case of a total occlusion, which is secondary to myocardial infarction, do you routinely do some physiological tests before doing the procedure in order to know whether the myocardium is viable or not? This is the first one. You want to answer this one?
Yeah, please.
Yes.
When we have, this is an absolute established algorithm in our CAD lab. When we are going to attempt CPO occlusion, we always confirm the viability of the myocardium. And if we have doubts, we perform a several ischemia detection test anyhow, if you don't have the conviction that your procedure is going to be useful, I think it's better not to do.
I'm not speaking specifically about this patient. This patient looks to have an ischemia and he has ejection fraction of 40 in spite that he hasn't myocardial infarction. I'm speaking in general, especially if the patient has having myocardial infarction before, whether you do this physiological test or not.
Yeah, we usually do it.
Yes, yes. The second question, in a case of a total occlusion, you start your procedure by integrate technique, or you can decide from the start to do retrograde technique according to the angiographic picture.
Yeah, thank you very much for this question. It depends on very much of the anatomy of the lesion, as you have pointed out. If you have a very high score, JA score, and a very good collateral, like in this case, you can do a first attempt antegrade, but in order to mark, in order to point out the direction that is going to have your retrograde wire. I think this is a good point. For sure, you can use other peaks for avoiding this. If you perform a CT scan in a very long CPO occlusion, you can predict the direction of the retrograde approach with proper decision. So many times, if we have doubts, we perform a soft first antegrade attempt, not more than 20 or 25 minutes, and then we proceed with retrograde.
Thank you.
If the case is a second attempt, we fail in the first attempt, and then we are approaching the CPO with the second attempt, we always go retrograde.
Thank you. If you have any question from the floor to Dr. Isaac, thank you very much. Thank you.
Thank you very much. See you later with the lab case.
I think now to complete this first session, we have another important lecture about a common complication we can see during our procedure, which is dying nephropathy. And we have our colleague, Dr. Hisham Abdelaziz. He will speak about zero contrast in complex PCI. Dr. Hisham? Yes.
Good morning, everyone. It's an honor to present in this course today. Thank you for the invitation. I'm going to start sharing. If anyone from the IT is there, please, I would like to share my screen, but it's disabled. Can you see my screen?
Yeah.
Yes, right.
Welcome.
So today I'm going to talk about zero contrast complex PCI. I have no conflict of interest to disclose. So what are the evidence here? So CKD patients are known to have worse outcomes and higher risk of cardiovascular disease compared to non-CKD patients. Unfortunately, these patients are less likely to receive invasive strategy. The benefit of this invasive strategy further decline with further reduction in the post-PCI patients. If you are contemplating any PCI procedure for these patients with advanced CKD, then it is recommended that the volume of the contrast media to be minimized. What are the prognoses of this CIN patient? Multiple studies have shown that patients with CIN actually have a worse long-term mortality. And this is evident with the higher CIN risk score they would have. So patients with a very high CIN risk score, more than 16, have a very high risk of mortality. The role of IVUS here is clearly evident from a trial done by Sakai et al. In 2019, which showed that IVUS-guided intervention compared to angiography-guided intervention would result in significant reduction in the CIN incidence and significant reduction in the need for renal replacement therapy. And finally, the ultimate CKD sub-study had showed that the IVUS guidance compared to angiography guidance in this patient has significantly reduced the incidence of CIN and target vessel failure. So at Lancashire Cardiac Center here, we use a very common and well-validated score to predict the incidence of CIN following PCI. It's Miran risk score. It consists of 7 parameters, and then they are integrated together to indicate what risk of CIN and risk of dialysis. So on the right-hand box, you can see that if the risk is more than 16, there is almost a 57% risk of CIN and a 12.6 risk of dialysis. So in the next few slides, I'm going to show what are the steps you need to do a zero contrast PCI using the Sync Vision IVUS co-registration system. So first of all, you would take the diagnostic angiography with minimum contrast use, preferably in a biplane cath lab setting, and then we give the patient time at least 2 to 3 days to check his renal function and to have an appropriate heart team discussion and discuss the benefit and the risk with the patient. And then if the PCI is indicated, we perform the PCI procedure exactly in the same angle as the diagnostic angiography. The guide engagement and the wiring is done using tactile feedback only. There is no contrast injection at all. Sometimes you can use saline injection, and if you are engaged into the left main or the RCA, you will notice T-wave inversion. You can also use calcium marker. You can also use roadmap from diagnostic images to help you to guide into the target vessel. Once you've wired the vessel, then cine acquisition without use of any contrast. Then once you have taken cine acquisition, don't change the table position or the C-arm, otherwise you have to repeat the procedure from the start. The software will prompt you to highlight the wire, the PTCA wire, from proximal, from the guide catheter down to the most distal visible end of the wire. And then you perform manual IVUS pullback at a speed of 1 milli per second under continuous fluoro. For the time being, it's only the Eagle Eye IVUS catheter that is used in this sync vision. Once you've done this, co-registration will automatically be created, and the IVUS images will now be fully integrated and co-registered with the artery. So in these few images, you can see now this is the end result. So on the right-hand side, you've got your angiogram, and the left-hand side, you've got the IVUS, the cross-section, and below it is the longitudinal section. The yellow marker indicates exactly where are you on the artery and when you move it. So the first slide, it is in the LAD. Moving backward, it's in the left main, and you can see clearly the IVUS images. And you can also measure the length of the lesion. You can indicate the proximal and distal landing zone, any need for any calcium modification, the length of the lesion. And post-PCI, you can assess your outcome as well. So a few cases to demonstrate how is this done. 8-year-old male who's diabetic with moderate LV systolic dysfunction, and his end-stage renal disease, not on dialysis, with a GFR of 15 mil. He had a previous PCR to the RCA 7 years ago, presented with inferior MI and had balloon angioplasty only to the circ, and his CIN score was 14. Just to reiterate again, all these cases have gone through an appropriate heart team discussion and were judged that they are not eligible for surgery. First case, this shows the distal left main and the blocked circ of his acute presentation, and disease mid-LAD, proximal to mid-LAD. A plain balloon angioplasty was done for this circ only, and then the patient was referred for initial surgery, and then he was a surgical turn down, and then decided to perform the zero contrast PCI. So one wire in the LAD without use of any contrast, and 2 wires in the diagonal to secure them. The benefit of this diagonal wire as well, they can act as a marker to help you in your procedure. Then perform the IVUS run. As you can see, the IVUS is demonstrated exactly where are you on the target artery. It enables you to decide the landing zones, whether you need any advanced calcium modification tools, and the appropriate sizing of the vessel as well. In this case, it was felt that the calcium is not significantly excessive, needing any advanced tools. So this is the yellow marker at the bottom of the screen, indicate the distal landing zone. This is the area where we wanted to target our calcium modification here using cutting balloon and angiosculpted balloon. Another area here near the proximal LAD, and this was the length of the initial stent we planned to do. So we targeted the area we have seen on the IVUS images exactly, with combination of a cutting and angiosculpted balloons. Then we decided to perform stenting of the mid-LAD first, and then we proceeded for a decay crush to the left main without using any contrast. So the first stent in the circ protruding into the left main, and then the crush, the standard crush technique, and then passing the balloon into the LCX. Sometimes you use an anchor balloon if it's difficult. And then the first case is standard now to use a 2-step decay crush with performing high pressure inflation in the side branch first, followed by inflation in the main branch, and then simultaneous kissing balloon. As you can see. And then finally, we used the main stent, the main branch balloon here protruding up to the ostium. And to nail down the ostium of the left main, we use the floating wire technique. As you can see, there is a wire hanging into the aortic root to avoid deep engagement of the guide. This also was done without using any contrast at all. And then performing the first pot, and then rewiring through a non-distal struts, and performing the second kiss, followed by the final pot. This shows the position of the final pot. Try to avoid the distal left main and the carina, otherwise it would be compromised. And then the final IBUS images, co-registration, shows that no distal dissection, well expanded and opposed stent, and satisfactory MSA. Back to the left main ostium. This image you see clearly shows that the distal carina is nicely opened, and you can see the ostium around 9 o'clock for the circ here, with very satisfactory MSA of 20 millimeters. At this stage, we are quite happy and satisfied with the result. However, we only use a 4 mil of contrast at the end for two main reasons: medical legal issues that we require to document proving the good result with contrast in most of the NHS hospital here, and just to avoid the very rare risk of having a distal wire perforation. So perform only a 4 mil of contrast injection at the end of the procedure using a biplane cath lab, which shows a very satisfactory result for this complex DK left main. Another case is an 82-year-old male, moderate LV systolic dysfunction, presented with NSTEMI, hypertensive diabetic with CKD stage 4 with GFR of 70 mil and CIN risk score of 15. You can see a critical distal left main with severe proximal LED disease, Medina classification 111. In this case, we decided to go up front with an intra-aortic balloon pump support during the procedure. So performing the first IBUS images, recorded at extra speed here for the sake of time of the presentation. So you can see that there is calcium, but the calcium again wasn't excessively needing any advanced modification tool. So we performed one from the LED and one from the LCX back into the left main. On the right-hand side, you can see clearly that you can delineate where exactly of the area you would like to land your stent. So performed the DK crush for this left main, stenting of the circ and then crushing, first kiss and then the stent with the floating wire technique back into the ostium of the left main, and then performing a pot, the second kiss, and then the final pot. This is the distal. The yellow marker indicates that where are you exactly on the artery, on the IVUS. This is the stented area at the mid segment of the LED, and then near the proximal LED, and again at the distal carina with very satisfactory MSA of 18 millimeters square. And then the final angiographic image just to document using 4 to 5 mil of contrast. Case number 3 is a 76-year-old male, diabetic, hypertensive, anemic liver cirrhosis with a GFR of 18 ml per minute with recurrent NSTEMI and moderate LV, dysfunction with a CIN score of 17, a heavily calcified proximal LED. This case, we decided to go for an upfront rota ablation using a 1.5 millimeter burr. So you use your standard workhorse wire like a sine glue wire, and then exchange using a microcatheter for your rota floppy wire, and then pass your rota burr as needed to ensure that the whole calcium is debulked, and then performing your initial IVUS images. You can use bookmarking facility as well. So you can see that most of the calcium is being debulked. However, there was one area we were worried about, that there was still almost like this area here, that there was still 270 degrees of calcium that need further modification. And therefore we used an IVL, shockwave balloon, to achieve good result here. So you can see multiple shockwave balloons used to target the area where we thought there is still large amount of calcium in the mid and the proximal LED. This is the final image following the IVL. You will see clearly there is calcium fracture at 12 o'clock here and 3 o'clock as well, multiple calcium fracture from the IVL balloon. We were quite happy to proceed now for the stenting. We used to overlapping stent in the LED, and this stent here was just landing at near the ostium of the LED. And in order to nail down the ostium of the LED, we used a guarding balloon from the left main into the circ. This is the final images showing on the longitudinal section, you can clearly see the well expanded and oppose the stent back to near the left LED ostium. And these are the final documentary images. Compared to the initial images, this is a satisfactory outcome. Case 4 was an 88-year-old lady with multiple risk factors and GFR of 23 ml per minute, presented with anastomie and moderate LV dysfunction with CIN score of 17. You can clearly see a very critical distal left main which is heavily calcified. So this shows how you can proceed with wiring without using any contrast, just using the diagnostic roadmap. And then we perform a pre-dilatation for the distal left main. Our initial strategy was to perform a DK crush in this lady. However, during the procedure early on, she was hemodynamically compromised, and we needed to change our strategy and implant an intra-aortic balloon pump to support the procedure. After performing an IVUS, we decided not to rotablate and just to perform cutting balloon and angiosculpted balloons to bail out the situation. So this is the IVUS images. It did show a moderate to severe calcification. Performed with multiple angiosculpted and cutting balloon near the distal left main, which in fact was inflated completely. Then we performed the left main LED crossover technique stenting using the floating wire technique. Then performed the final post dilatation, and this is the final IVUS images. Stent is opposed and expanded with a very satisfactory MSA, with no distal or proximal edge dissection. Final images using a 4 ml of contrast shows a very satisfactory outcome compared to the initial pictures. Another case, 83 years old male, moderate to severe LV systolic dysfunction.
Hisham, you hear me?
Yes.
I think we have a live transmission just now. And we have time for one question.
Okay.
We will be satisfied by your 4 cases before. This question, depending on your presentation of zero contrast in these complicated cases and the use of certain investigatory like the IBIS or so on to do that. This is not done routinely in our CAS lab. If you have any recommendations for preparing the patients with borderline renal dysfunction, and at what level, if the patient have a GFR of a borderline, you can contact your nephrologist colleagues to indicate whether the patient is going to have a dialysis after or even before. You have some comment about these questions?
Sorry, so the question is regarding what are the precautions we need to prepare these patients?
Yes.
Have I got it right?
Yes, this is the question number one. And if you, if the patient have a borderline impairment in his renal function with GFR, for example, of 50 or something like that, whether you ask your colleague in the nephrology department that he may need dialysis after or even before?
So for the first question, the precautions, the most important precaution is actually the hydration. So even when we perform zero contrast PCI, because contrast is one of the factors that causes CIN, but it's not the only factor. So hydration is very important in these patients. Regarding contacting nephrology physician to support the procedure, we stopped having any nephrology input into our CKD patients who are going to be proceeding for PCI after we have developed this solid zero contrast PCI procedure, as we are quite confident that most of these patients up till now don't suffer from any CIN.
Thank you very much. I think we have to finish now in order to start the live demonstration. Thank you very much.
Thank you.